Welcome to our 50th anniversary celebration webinar, OT and Low Vision, Assessment and Intervention for Acquired Brain Injury. Over the next hour and a half, we look forward to discussing OT's role in low vision. After participating in this webinar, please be sure to visit the UCOT website to complete the competency assessment and provide your contact information for a certificate of completion. Without further ado, I'll turn it over to our co-hosts, Dr. Brandy Pate and Dr. Kelly Hartwick.
Hello everyone, we welcome you to this webinar that we're going to do on low vision. February is low vision month, so we're going to do a topic that's near and dear to our hearts. It's on occupational therapy and low vision, and we're going to focus in on the assessment and intervention for acquired brain injury.
So we just want to introduce ourselves. My name is Kelly Hartwick. We are both graduates from the University of Central Arkansas back in 1998. And I'm just going to say we both received our OTD low vision rehab certificate in 2021 from the University of Alabama at Birmingham. And then we both graduated in 2022 with our post-professional OTD. Both went in 2023 and passed the CBIS Certified Brain Injury Specialist certification in 2023. I have taught here at the University of Central Arkansas in the OT department for 4 years now.
And I've taught here since 2016 to 2018 just in labs, but since 2018 full-time. And then we both worked together at a rehab facility for about 15 years. So you can see that we're very similar. And our career path we've been blessed that we could do that alongside each other. So the picture on the right is when we graduated with that post-professional doctorate. So we did not know we were going to go back to school in our 40s, but we did, and are thankful for that education. We had a phenomenal experience with UAB. And then the picture at the left in Kansas City is from AOTA conference that we went to last year. So we teach at UCA, and we did graduate with our undergraduate degree from UCA. And like I said before, UAB is where we spend our time with our low vision rehab certification in addition to our post-professional doctorate. So we're going to dive in. So we're going to dive into this topic. It is dense. We're going to cover it at the best of our ability to keep it within an hour for you guys, but please feel free to email us if you have additional questions or you just want to collaborate. So this is just a slide that has our learning objectives, and we're not going to go through these verbiage wise. I'm not going to communicate long on this, but you can come back to the slides. These are the things that we're going to make sure that we cover within this webinar, just to give you an overview of ABI and low vision. So you probably are well aware of this, but we just want to make sure that we make note that within our sensory system, vision is our farthest reaching sense. It is what gives us meaning to what we're seeing and what we're doing. And between 70 to 80% of how we learn and interact with our environment is mediated by our vision. So it's absolutely integral that we know that and we recognize that when we encounter our clients with acquired brain injury that have lost that sense, because it affects everything. Visual functions are represented in every lobe of the brain. While many of us may think about the occipital lobe immediately, it's important to recognize that vision is affected everywhere. So we can't discredit that. And this advanced practice degree for both of us came because of years of treating brain injury and stroke clients and wanting to learn more on how we could affect them and their occupational performance through the sense of vision. So here's a little anatomy review. Not sure when any of us or the people that are listening took it. Maybe recent, so you may be really equipped with that, and it may be like us that we practiced a long time ago. So this is a review for us. So the cornea, so this area right here, is the covering of the eye. The cornea protects the iris and the lens, and it is the barrier to keep the eye healthy. With injury, like a brain injury, it can get susceptible to multiple different things, and then due to that, it can cause major issues. So we have to respect the cornea and that it covers and protects our eye. The retina which is over in this area right here, is a thin layer of tissue, and it lines the back of our eye on the inside. It's located near the optic nerve, and it allows information to be brought in to the system for us to be able to see. And then the lens of our eye, which is going to be right in here, it's what keeps things in focus for us, and it can change with injury, and it can also lead to acuity changes, so how we see the information. And then the macula, which is going to be back over here, it's what translates light that enters into your eye into the images that you see. So it's responsible for our central vision, which is what is directly in front of you. And then when you look at your pupil, it is the round opening in the center of the iris. And it is the color tissue is what makes the eye color at the front of the eye. But the pupils will change size to let light in. So the brighter the light, the smaller the pupil. So when it's darker outside or you don't have a lot of light, you're going to see that the pupil is larger. With somebody with a brain injury, they may have a pupil size that is not what it needs to be. And so you will notice that immediately. That's something that you can identify when you look at your client. So just recognize that you have to know kind of just the basics. We could go into all of this, and we'll go into the muscles in a further slide, but that's just hitting some highlights on the anatomy of the eye. So what is low vision? So low vision is a condition that cannot be corrected by medical or surgical intervention. So if you're nearsighted or farsighted, you can go to the eye doctor and they can give you lenses and they can correct that. That is not low vision. Low vision is something that cannot be corrected by medical or surgical intervention. It allows for some usable vision, but it's severe enough that it interferes with completing daily activities. And that's something that is very important to us as occupational therapists, is how do they complete those daily activities? So we want to meet them and work on how they can use their usable vision. So some definitions that you should know with low vision is that legal blindness is any degree of vision loss that ranges from severe impairment to total blindness. So when you look at your prescription from your optometrist or ophthalmologist, they're going to give you their visual acuity. So legal blindness is visual acuity of 2200 or less in the better eye, or a visual field of 20 degrees or less in the better eye. Whereas low vision is a visual impairment with a visual acuity of 20/70 or worse in the better eye with standard correction. Many people that have been diagnosed with low vision are also legally blind. So, this is something that we all know, but I think it's important that we say this so that you can recall this and just allow yourself to just soak in that the brain is actually what sees, not the eyes. Our eyes is just the conduit that brings that sensory input into our brain. So then the brain is going to perceive and interpret that information based on what has happened to us in our past and what's happening in our present. So our context and what we've been exposed to is really important because that gives meaning to what we're seeing. When we cannot predict accurately because of impaired vision, then we have stress. And so from that visual stress, you will notice that clients may keep their eyes closed and not open their eyes. They may have visual hallucinations where they're seeing things that are not actually there. They may be very anxious. They may be fearful. And they are going to express this sometimes by not vocalizing this after a brain injury, but you may see increased agitation. You may see that they want to sleep all the time. You may see that they avoid or withdraw and they don't want to communicate. You may see a family member and they may not recognize them and they're frustrated, and the family member may not understand that many of this can be just because the brain is not interpreting that information. And that's our job to communicate that to them. So cortical lobes involved in vision. I said earlier that every lobe has a role within our vision system, but the frontal lobe, which you can see in the picture here, which is in blue, that directs our purposeful search of our environment. Okay, whereas the parietal lobe is going to monitor the movement and the peripheral environment. So it's the posterior eye field. So it's back over in this section right here. And then our temporal lobe, which is going to be over here, is the area that's going to activate attention to search for details. So you've got to be able to have attention to use your eyes. to be able to find those detailed components. And then the cerebellum is going to allow us to have that coordination. So our eye-hand coordination movements are routed here. It gives us control over direction, effort, force, and timing. It allows us to do it without falling. It allows us to just be in a more coordinated and controlled environment. If that cerebellum is damaged, you may see nystagmus, and you may also see dysmetria, which both are things that you're going to see as clinicians with clients. So you can't discredit how integral vision is within the brain, and really this just gives you just a small piece of that. But you see the different lobes, and we talked about the frontal, the parietal, the cerebellum, and the temporal, which obviously the occipital lobe has a huge, because vision is the primary area within the occipital lobe. So that also is going to lead to like color blindness and them not being able to identify specific aspects of vision too.
Okay, so now let's review this lovely slide of the visual pathways. So I love that this is color coordinated because it really helps you to understand, what each eye is actually seeing. But if you superimpose the brain on top of this, you can look here. So these are the eyes. So your frontal lobe would be here and your occipital lobe is here in the back. And so you have the information, coming in from the eyes, since they're, like Brandy said earlier, the conduit to the information. And then they carry the information to the retina, and then from the retina through the optic nerve right here. So this is your optic nerve from the back of your eye. And then right here at the X, the cross, is the optic chiasm. And at the optic chiasm is where the information actually crosses over to the other side. So we'll have a slide later where we'll talk about lesions in specific areas of these pathways, but just know that right here at the X at the chiasm is where the right eye takes the information to the left side and the left side to the right eye, vice versa. So here you've got your optic tract that is right after the chiasm, and then it goes on to the geniculocalcarine tract. That's a mouthful to say. So later we'll talk about that. There's a lot of damage that can happen in this big pathway right there, through brain injury, like traumatic brain injury, stroke, anything like that. Depending on where that lesion is specifically can really impact where the visual impairment is. And then so all this information is carried again from your retina through your optic nerve, down the optic tract, and then it makes its way all the way back to the occipital lobe. And so, it doesn't look like a lot of space there, but that's a lot of information that has to travel. So there's a lot that can go wrong between, the eyes to the occipital lobe. But we'll talk about that a little bit more in future slides. So I think it's important to understand the way that the visual perceptual information comes in and is processed. So this particular slide was made by our professor, Dr. Mary Warren, who is just, wonderful and all-knowing about low vision. So we learned so much from her in our coursework. But she developed this visual hierarchy to kind of help you better understand the foundational skills that are needed for vision and visual perception. So at the bottom of the hierarchy are visual acuity, visual fields, and ocular motor control. And this is just saying these are the basis. This is a foundation. So these need to be intact before you can move on to the next, which would be moving into visual scanning and inattention. And then the next layer would be visual memory and pattern recognition, visual cognition, and then adaptation to the environment through the use of vision. So just understanding that each layer builds on the next, and if there is a disconnect with visual acuity, then it is going to impact visual attention and visual memory. So just knowing that those are going to carry over from layer to layer. And that they all, are interchangeable and they serve each other, and the loss of one impairment at one level can impact the next. So this, I feel like, is an impactful slide just to have a good understanding of the overall process. Just a good knowledge that low vision can be progressive, whether it is brain injury related or age related. It is progressive, and it impacts multiple facets of your life. So it can happen suddenly, it can be unpredictable, after an injury or something like that, or a stroke, that, suddenly you have this take place, and, your brain doesn't know how to interpret the information. There are a lot of mental health and psychological adjustments that may go along with low vision, because if you think about how your occupations can be impacted and your independence, there's definitely, that mental health adjustment that goes along with that. And again, like I mentioned, the aging part of visual impairment, it can, be co-occurring with that. So you could already have aging type situations going on with the eyes, and then have a brain injury on top of that. And so just knowing that there are a lot of aspects of vision besides just the getting the information that could be impacted and impact the whole person. So when we talk about components of vision, there are several, and we're just going to touch on a few. But acuity is going to be, a big one, and that's how you can take in the information from the environment and see things in detail. So just a bit of a review: presbyopia is the condition that happens with aging, where the lens of your eye becomes a little bit hardened. Usually happens, in your 40s. I'm definitely dealing with that at this point. This is when you have your readers and you're pulling them up and down, off your eyes. So, you can typically see far away, but it's up close that becomes difficult, just because your lens can't, contract like it used to. And then myopia has to do with nearsightedness. Hyperopia is farsightedness. And just knowing that these things are typically corrected by lenses, through your optometrist or ophthalmologist. And so those are typically corrected, the acuity side of things. We talked about the low vision cannot be corrected. And so there's many things that can go, wrong beyond just the acuity. But this is first where you're seeing the information and taking it in from your environment. Another component is contrast sensitivity. So this is just the ability to distinguish between shades of darker light, and being able to, shades of gray, shades of even different shades of white that may look different. And if you think about how this impacts function, if someone has, a contrast sensitivity dysfunction, is they may be more prone to falls in the environment. So, not being able to see a step up or a curb drop, or, a change in the texture that you're walking on, going like from grass to gravel, things like that. So it's important to note that contrast sensitivity can really impact safety and function. So it's an important thing to assess with our clients. Then we have ocular motor control, which is just the ability for the eyes to move smoothly and coordinated, so we can see and we can be able to look through our environment for things. There's a lot of eye muscles that are involved in this that can be impacted from brain injury as well, and we'll talk about that a little bit more. But just know ocular motor control is a really important area to assess in vision. Another component of vision is visual perception, which we talked about a little bit in the hierarchy, and how we interpret that with our environment. So it's basically, once your brain gets the information, how it interprets that information and knows what to do with it. And depending on the lobe of the brain that's impacted, just, you being able to process that information appropriately, again, to know what to do with the information for your environment, for safety reasons, all of those things.
Okay, so eye dominance is an area that is easy to understand. It's just looking to see which eye is dominant. But prior to going through this program, this was not something that I ever assessed with my clients. But Why I have no idea, because we all know that we do many occupations in which we need to know which eye is dominant, especially like just coming to mind if you're taking pictures and you're looking through your camera, you want your dominant eye to be able to do that. So this just is a slide that lets you know that it's important that we do this first. We assess when evaluating visual acuity which eye is dominant, and you can do this really easily. So this is an example, a couple of different ways that you can do it. You can roll up, you can take a paper towel roll, you can roll up, basically anything and hand it to them and have them look at an object, and whichever eye they bring that to is their dominant eye. So you don't tell them that you're looking for their eye dominance, you just hand them this, paper towel holder, whatever you're going to use, and say, I want you to look at this image and see which eye they bring it to. And this on the far right lets you know how you can do that with just your hands instead of if you don't have an object with you to be able to test that. So consequences of vision impairment. So these are the things that our clients may be telling us that they're seeing. So they can have difficulty completing vision-dependent activities. And so when I say vision-dependent activities, it is something that they need their vision to be able to do safely. So like we can get ourselves dressed probably pretty close without having full vision. It's difficult. May not be perfect without errors, but you can do it. There are many things that, especially our instrumental activities of daily living, that require our vision. So you automatically are going to notice that they're having trouble with that. They have a slower processing speed. They make errors in their decision making. They become tired. They're going to close their eyes. A lot of times they'll complain of headaches because trying to use their eyes creates visual stress. And then you will ultimately see that in the end stage, or just while they're dealing with this, they just quit doing things that they love to do. So those occupations and those activities that we do every day and we take for granted, they start not participating in those activities because those activities cause stress and they cause fatigue and they cause frustration because they're not able to use their vision the way they did prior to the injury. So challenges in addressing visual impairments. Many times vision is mislabeled as a cognitive impairment for a lot of our clients. And so we, as occupational therapists, need to be able to, triangulate what's going on with them and see that this is that the challenge is vision so that we can assess and intervene appropriately so that we can give them their optimal function. So there's a complex picture of disability for our clients. So our clients that have had strokes or they've had brain injuries, oftentimes they also have motor impairments, they have language impairments, they may have a cognitive impairment. And so vision is not always something that is assessed individually as a result of that. Client often presents just as an ambiguous picture, and what that means is that it oftentimes can be masked, and it can be we can look at it as motor or as cognition. So we just have learned over the certification period and just from decades of practicing that you really need to isolate and test those separately so that you can really hone in on what is the problem. Is this cognition? Is this motor? Or is this truly just a vision impairment? And sometimes it's going to be both. It's difficult to tease out the visual impairment. It requires observation, and clinical observation skills should be a part of our assessment process. But oftentimes just with time, we get through our standardized and non-standardized assessments and we write it up and we haven't even taken the time to just, what are we seeing? And we see that in our intervention session, and then we have to go back and assess that. So you have to recognize that as occupational therapists, we have a thorough understanding of anatomy and neuroanatomy. We have that as within our background, within our education, but we also need to make sure we take that extra step to understand vision and vision impairment. And we do that through teasing that out with assessment, and we'll get through in a later slide where we'll talk about the BIVABA, and it's an excellent tease out tool for you to have in your tool belt to be able to isolate and know what area is being affected. Vision impairment can slowly reveal itself, so it may not be something that we see initially because of medication, because our clients are sleeping more and they have more fatigue after a brain injury, and sometimes they're staying up all day and night because of a brain injury. So where they're at in their phase of recovery, we may not notice this, but that doesn't mean that we don't come back to assessment, because we know that assessment and intervention is not linear. You're constantly going back and assessing and reevaluating your clients. So once you notice this, then come back to that assessment process and be detailed with your client. And then vision impairment persists after other impairments. So, while we may get our swallow function back, or while we may improve our paralysis and paresis and management of that, a lot of times as a result of vision impairment, this becomes something that our clients have to compensate. They can't remediate. They can't get that return in that 2-week rehab stay. So that's when we have to know that while they're still dealing with that, we should still be addressing that with our clients and the caregivers. Okay, so assessment. So right out of the gate, acute care, you go to see your client. Oftentimes their glasses were broken during, whatever happened, or maybe they didn't even get brought to the hospital. So before you ever start the assessment process, you should ask yourself, and you should ask your clients, whether or not they used glasses before, and if so, then we need to assess them with their glasses. So the very, very first out of the gate is bring what you used before. Is that contacts? Is that glasses? Is that a magnification system? Making sure that we're seeing our clients with what they were doing in their natural environment. During your history and review, when you're looking at their past medical history, make note if you see any age-related conditions that might play a role with this, like macular degeneration or glaucoma. Making sure you note if in the H&P it says that they, sometimes you'll be blessed to have their acuity level if you work at a facility that an optometrist or an ophthalmologist is on the team, and sometimes you don't have that information. So find what you can in the past medical history to equip yourself. And then observe during functional tasks. So, often with clients who have double vision, they're going to close one of their eyes. They may squint. They may pass point. So they're trying to get to where they can show you something, but they don't quite get there. Some of the times we'll see that as motor. We may think that that is a motor impairment when in fact it could be a vision impairment. You'll notice with our clients with hemianopia that they may tilt their head in different positions so that they can see and they can scan their environment. So those are good clinical observations to make note of when you watch them do functional tasks. Do they complain? Do they tell you that their vision is blurry? Do they tell you that they're seeing 2 or 3 images of you when you're trying to assess them? Is it reported by them or a family member or maybe even a nurse that they're having headaches and they're having nausea and vomiting? These are all very important things that you need to make note of. And then look at their eyes. Look at the symmetry. So go back to that anatomy slide. Look at their pupils. Is it in alignment? Look at their eyelids. Are they able to keep it open, or are they not able to do that? That becomes very counterintuitive if you have someone who's having trouble with their eyelids. And I've been in situations where the optometrist has recommended that we keep their eyes shut, because that we will have very dry eyes, or our clients will have that if they're not able to have the ability to do that from their cranial nerve function. And then do they have nystagmus? If they are doing an activity and you're seeing their eyes move constantly and they're not able to write that, that's something that you want to note in your assessment process. And then we'll go over the different 9 cardinal points of gaze that our eye muscles do, but is that when you're doing tracking with a pen light or a pencil, whatever you're looking at, eye movements at, are they able to do that? Can they move their eye up and down and side to side, and can they also move it within a diagonal plane? And if not, then we want to make sure that we make note of this. So all of these things involve some clinical observation skills, which as occupational therapists, that's one of our tools in our tool belt. Okay, so this is just talking about using both of our eyes together. That's called binocular vision. And so we use both of our eyes together to provide our brain with that perception of that one image. So 2 of our eyes are looking at something and then we identify it. It's important that we have binocular vision for all of our occupations, but especially for reading and fine motor tasks and anything that we have to visually monitor using our hand. Also gross motor, like if someone's throwing a ball at you, or if you're throwing or kicking a ball, driving, parking, all of those types of things require binocular vision. So with that, we have sensory fusion, in that we create a single image out of the two different images that are being sent to the brain from each of our eyes. So if we have an impairment, and we have an impairment with sensory fusion, then at that point we start noticing that there's visual stress and that there's errors and difficulties with that. We're really dependent on our eyes maintaining that alignment, and we require that for motor fusion. So ocular motor control, you saw this as one of our foundational skills that we look at with vision. This is when our eyes move together for one purpose. We want our eyes to move together to place and keep images that we're going to view on our fovea of both eyes so that they can see it clearly and in color. And this is difficult because we move all the time, and we turn, and we change our head and our body position. So many areas of our brain are going to contribute to our ocular motor performance, and our eye movements require that complex combination of our cortical, our brainstem, and our cerebellar control. So within this webinar, we're going to teach you how do you test for ocular motor control. I'm sure that you can note that there is a problem with it, but how do you hone in and test it, and then also how do you provide intervention for this? Okay, so at the ocular motor system, control of eye movements, I'm going to let Dr. Hartwig take in on this slide.
Okay, so controlling the eye movements. So obviously, like Brandy just said, it's a complex coordination of all of the muscles, all of the parts of the brain to put all this together. There's 3 cranial nerves that that are involved in vision. Not typically. Cranial nerve 3, which is the oculomotor nerve, 4, which is the trochlear nerve, and then 6, which is abducens. So those are the most injured cranial nerves, aside from the facial nerve, cranial nerve 7, that is often injured within a brain injury. So just taking note of those cranial nerves, and we'll talk about them a little bit more, I believe, on the next slide. So lesions that involve cranial nerve 3, and we'll talk about the eye movements a little bit, but your eyes typically down and out, so looking down and rotated out, so you can't move your eyes up and down so good. Convergence is going to be hard. It's going to be difficult for these clients. They're going to have double vision, like side-by-side double vision, which is lateral diplopia, is what is that called? Depending on the extent of this injury, they may have partial ptosis of their lid, which is like a drooping eyelid. If it's not complete, sometimes that they won't have that particular symptom. Typically, the pupil is also dilated if it's a more intense injury. With the incomplete lesion, you're going to have exophoria, which we'll talk about in a minute as well. And some of the things that are going to be hard for clients that have this particular cranial nerve lesion is those near vision tasks that require detail for like reading and things that you do up close. They may also be sensitive to light if they have that pupil impacted with a dilated pupil. They may have some light sensitivity. Then when we think about cranial nerve 4, you're not going to see as much impact on the eyes being deviated. Sometimes you can look at your client and initially know, what eye is deviated as opposed to the other. But it's a little bit harder to tell on this one. This one is also the most susceptible to injury just because it has the longest pathway through the brain. So there's lots of places that it can be injured along the way. A lot of times you may see a bilateral lesion. So you may see both the left and the right cranial nerve 4 impacted, which is not always the case with 3 and 6. Your eye, maybe when you look at your person straight on, the eye is a little bit elevated as opposed to the other, but they also may have a hard time moving their eyes down and out, which this also, of course, impacts reading, near vision tasks, but also safety things like being able to look down to walk downstairs is also going to be difficult for these clients. So they're really going to have to compensate with that. Then we have cranial nerve 6, which is a little bit easier to tell because the eyes may look crossed at times. And so that means that they're inwardly rotated. With this one, you're also going to see that side-by-side lateral double vision for the images that the client sees. They're going to complain of seeing the images side by side. I didn't mention that, but for cranial nerve 4, it's up and down double vision typically, vertical. diplopia for the cranial nerve 4. So that's going to look a little bit different. Sometimes that's a dead giveaway for that. Some of the occupational tasks that are going to be difficult, things like driving, walking, safely ambulating through the environment, being able to, avoid obstacles, things like that. Distance activities like sports and things that you're going to have to look in the distance for are also going to be hard because of the inability to track and coordinate those eye movements. So these are all of the muscles that are involved in moving the eye. So as you can tell, if one of these muscles are impacted, it's going to impact, the overall movement of the eye. So you have the superior and inferior rectus, which are responsible for moving the eyes up and down. We've got the medial and lateral rectus, which moves the eyes side by side. And then you have the superior and inferior oblique muscles, which are more for rotation and torsion, more like diagonal movements of the eye. And so there's pictures of all of these and how primary position of the eye and what each of these muscles will do. So this is when we talked about the 9 cardinal points of gaze. So typically when I see a client, I'm going to take them through every one of these eye movements, and it's just look up, look down, look left, look right, and then have them look diagonal in each direction. And you can make note if they have a hard time, or maybe their eye bounces when you move from up to down, and you can kind of note which eye maybe has difficulty and which one may be lagging when you're doing those scanning activities. Now, diplopia, which is a hard word to say for double vision, basically, and this is when the image is doubled. And this is just the lack of sensory fusion. So, we talked about sensory fusion in one eye. Each eye sees an image and then it superimposes together. This is just your eyes aren't seeing the same image. And so when they're superimposed, they are doubled and they're not right on top of each other. So this is going to be one of the symptoms of adult acquired paralytic strabismus. This is just that the eye may be paralyzed in moving one of those muscles, is impacted and isn't able to move the eye appropriately. So some of the symptoms from double vision, of course, you're going to see that doubling of images, but if it's not as impaired, it may be more like blurry images, or maybe they look a little crooked or misaligned, maybe not full-on double vision if it's less impacted. So just knowing for function, this can impact eye-hand coordination, just being able, postural control, position in space, if you think about how that impacts your vestibular system. And just the inability to see binocularly. If you think about, if you put your hand over one eye, you are not seeing depth perception. So you're just seeing a single image. And so that really can impact how you see your environment, especially if you were walking and you had, and you're only seeing monocularly. It can really impact that. We talked a little bit earlier about compensation for the double vision. Like a lot of times clients will turn their head or close their eye, and these are the things that you're usually kind of looking for just in the back of your mind when you think maybe this might be an issue. Sometimes they'll just tell you outright that they're seeing double. And again, you might have like the side-by-side double vision, or you may have the vertically, like it's stacked on top of each other, and that really depends on the cranial nerve impacted. I talked about like if it's as impaired or not as impaired. Atropia is a constant, more like a paralysis of the muscle. So if you had constant double vision, that would be more considered atropia. Aphoria is more intermittent. So a lot of these clients, maybe they fatigue by the end of the day or by, lunchtime, and they've worked so hard and they've done well and didn't have double vision, but when they lay down at night to go to bed, it really, kicks in because they're fatigued. And so this would be more considered aphoria. And so we'll talk a little bit more of that, I think, on the next slide. This is how you classify, for documentation or when you're observing your client and how their eyes turned. This is just how you're going to make note of that. So just know it's going to either be phoria or tropia. So esophoria, because that is going to be the one that's maybe intermittent. And so eso means your eyes turn inward, so they may be more crossed. Exo means your eyes are going to turn outward, so they call those wall eyes. So it's more like they move to the peripheral side. And then hyper, like a hypertrophia or hypophoria, your eyes are turned upward and you're not able to pull them down. And then hypotropia or phoria is your eyes are turned downward and you can't pull them back up into position. So that's just how you would describe that eye movement that you're seeing. And essentially it's whatever muscle is impacted. It's not pulling its weight. And so that distinguishes which way the eye turns. So some of the symptoms that you're going to see with these oculomotor impairments that we've talked about, this is kind of a repeat again. You may have blurry vision, double vision. Some people describe it as crooked vision. I have heard clients say that before. You're going to see a lot more stress and fatigue and headaches, and they're going to get agitated and just like avoid trying to do things. These are those clients that don't want to get out of bed and come to therapy because, you know, they want to have the covers over their head, basically. You're going to see decreased attention, which we're going to talk a little bit more about some of the other side effects of that, but decreased attention. For us as OTs, like within what we call our OT toolkit, that there are certain things that are kind of in our scope of practice and certain things that we're going to refer to other disciplines for. And for treatment of oculomotor impairment, really the only thing within our scope of practice, because this is often kind of a temporary thing that they may have double vision, is occlusion. And that we'll talk about here in a minute. Prisms or lenses, eye exercises, and that's kind of a controversial subject. And then eye surgery is going to actually be done, you know, by the ophthalmologist. Optometrists may, you know, put prisms on the client's glasses to help deflect the image and help them to adapt. But just know within our scope of practice in dealing with an oculomotor impairment, it's typically occlusion that we can add to our treatment session just to help with that visual stress so they can be, because they can perform their ADL tasks and occupations. And we'll talk more about that later. But convergence insufficiency is another one of those inability to bring the eyes in, like to follow an object in. And if you think about in the grand scheme of things that are going to be impacted with convergence insufficiency or more like reading tasks and things that you're going to do up close to be able to bring the eye in and focus. A lot of times when clients have trouble with this convergence insufficiency, they're also going to have headaches and fatigue and eye pain and probably avoid reading because it's, you know, frustrating and hard for them. This is something that you can test pretty easily. We'll talk about that I think when we get to our assessment intervention pieces. But just know this convergence insufficiency is really, really common with acquired brain injury. There are some studies that show this one here that's listed. 42% of clients with TBI and 35% of clients with stroke experience convergence insufficiency. That's listed wrong. But just know it's something to be looking for. Okay, so think about the types of eye movements that are involved just for everyday tasks. So eye movements that change that line of sight, you know, are going to be more like saccadic eye movements. So that's being able to quickly shift your eyes between two fixed points. So this would be like scanning a crowd to look for an empty seat whenever you walk into a classroom, or even following, you know, your dog that's running across the street and you're trying to see them, they run out of your sight. So this is being able to chase that, follow that with your eyes, and it's more of a quick type movement. So some of the movements that help with vision stabilization would be more like smooth pursuits. So this is staying on a fixed object. So being able to find a target that's not moving and scan for it. And you do have to move with the velocity of that target. And saccades, like if you are following a target with your eyes and it moves really quick, that's where the saccadic movement kicks in. But if it's a slower, more controlled movement, you're using your smooth pursuits for that. So just know these are things you're going to assess, whether it's quick movements or slow movements with scanning. You've also got the cervical vestibular ocular reflexes that are really more of a vestibular response to movement, like with your head position, when you're moving positions. And it's also something that is awfully common with acquired brain injury, being able to maintain focus on a target while you're moving. So this is another thing that you may have to look for a little bit.
Okay, I'm going to talk a little bit about the visual field, and the visual field is the area of the visual field that can be seen if we're looking straight ahead. So you can see by the image, there's a portion that our right eye sees, and there's a portion that our left eye sees, and then in the middle is the portion that both eyes sees. So when you look at our visual field, we have about 180 degrees horizontal side to side, and then we have about 135 degrees vertically within our visual field. So we've probably all seen visual field deficits within acquired brain injury. This is probably one of the things that we see more often, or at least I felt like that in my practice. It was difficult always to assess and intervene until I got the certification, but I felt like we could identify visual field deficits pretty commonly. This happens because anywhere that there is damage along the pathway where visual information is relayed from that retina to the occipital lobe can cause a visual field deficit. The most common deficit that we see is the homonymous hemianopia, which is caused from damage along that genitocalcarone tract that we saw on a slide earlier. So, go back to that anatomy slide, re-look at where your retina is, where your occipital lobe is, and then go back to that slide where we looked at the tract, and that is why this happens. And so it's good for us to go back and remember that. So hemianopia, sometimes it's called hemianopsia, same thing. It is loss of vision in half of the visual field of your eye. So homonymous means that the deficit is on the same side of both eyes. Most likely this happens in a PCA, a posterior cerebral artery stroke. And sometimes this can also happen in an MCA, a middle cerebral artery stroke. So you should get that information about where the stroke happened in your H&P. I mean, it doesn't always happen, but a lot of times you can see that. So that should bring immediate notice to you when you do your review that, oh, this is a PCA stroke. I need to make sure that their visual field is intact. It can also present with visual loss of a quadrant of one or both eyes, meaning it can happen in the top portion of your eye, or it can happen within multiple quadrants. And there's a slide that we'll go to later that will give you a lot of life that we wish we would have had earlier in our practice for sure. So the most common lesion site, we already talked about that. And so we're going to look at the PCA and the MCA occlusion. So a PCA stroke, oftentimes they're walking, their motor function is really well. And so oftentimes they don't get referred for therapy. These are people in acute care that get sent home, but they know something's wrong and they're avoiding occupation. 70% of our PCA occlusion have homonymous hemianopias. And this accounts for about 5 to 10% of our strokes. So you can really advocate for your clients by making sure that you get that referral for your clients that have the PCA occlusion so that you can do a thorough assessment for a visual field deficit. Often, like I said, they have really good motor function. So these are our clients that are walking around doing well, and so they get sent home oftentimes to deal with this on their own. Our MCA strokes typically are going to end up in an inpatient rehab or a skilled nursing facility for rehabilitation because they have more involvement. They have both motor function involvement. They may also have aphasia. They have neglect. A lot of times, this MCA stroke will also have a hemianopia as well. So just recognize when you just right out of the gate do your chart review, if you see PCA or MCA, that you need to be aware of their visual field and assess for that. I'm going to let Dr. Hartway talk about this slide. This is she does a wonderful job on this slide. And like I said, this brought life to us. We wish we would have had this information decades ago when we were treating our clientele.
I do love this slide. It just makes so much sense. So if you have a good understanding of the visual pathways, then you know if it's blocked. So these little red lines here are the lesions that could potentially happen. And so remember we said that before the optic chiasm that it's same side. So just know if you have any lesion before the optic chiasm, you're going to lose, and really right here, it's going to be total blindness of that let's see, this is the right side. So that would be total blindness of the right eye before the chiasm. Now, right at the chiasm, here at number 2 and number 3, those are both, like this is right in the center. So if you look over here, this would be like bitemporal hemianopia because it's only impacted the temporal side of each eye. And if you look at number 3, which is more on the right side, you're going to have more of a hemianopia. It's called a bipolar hemianopia. Oh, sorry. No, just the right nasal hemianopia because it's only at the right side, but it is right at the chiasm. And so then once you get past, this is more of your optic tract when you get to 4 into the calculate body. I have a hard time saying that. It's like a mouthful. I wish that I had like an abbreviation for that. That would make it so much easier. But it's just like light bulb movement. So if you look at these radiations, the way that they come through, like if it's just a partial lesion, like for number 5 here, if you go to number 5, that's when that quadrantinopia happens, where maybe you only lose a partial piece of the visual field. Whereas for number 7, if it's all the way across through all the optic radiations, that's where your homonymous hemianopia comes in. So it really depends on how dense your stroke is and how, exactly the location. It really is the telltale sign of what kind of visual field impairment it is. It's almost, interesting if you assess the vision and do some of the tests that we're going to talk about, and you can really see where the impairment is, and then you go back and you kind of look, then it kind of makes sense. So you can be able to tell what you may see and anticipate some of the deficits you may see if you know exactly where the lesion is. So hopefully that makes sense. Hopefully you love that slide as much as we do.
We do love that slide. So we'll just kind of go through some things that you may see with our clients who have hemianopia. So they have behavior changes that contribute to the limitations in how they perform their occupations. So their search pattern is limited, okay? So that and it really depends on where, what type of hemianopia they have, but it's limited from midline to the unaffected side. They scan very slow to the side of the deficit. Sometimes they don't scan to that side at all. They miss or misidentify details on the affected side. And they have difficulty tracking their hand if they're performing fine motor tasks like handwriting or if they're doing a knitting or anything like that. So they have trouble following their hand as a result of the hemianopia. So other influences on hemianopia with functional task. So this is when we, collaborate with our PT friends with mobility and navigation, because as a result of this hemianopia and field cut loss, they may not see the surfaces and the support surfaces when it changes. They may be fearful of falling. You may see these people just looking at their shoes the whole time that they're walking because they are unable to manage what they're seeing when they're looking up. These are the clients that we're telling constantly to look up and to scan their environment. They stop to search when they're walking. So they may stop often, and so you may think that it's fatigue while they're stopping, but they're actually trying to use their visual field and search what they're seeing because it's limited. They're anxious if they're in a crowded area. So you take this client to a grocery store and their anxiety is very high. So this is something that we should practice with our clients before we put them in that situation. And so this would be a great community task. Very stiff movement gait patterns, and that's because they're stopping and starting so much because they're not able to take all of that in because their visual field is cut. Navigation, so like if I'm trying to map out my environment, trying to get back to my room, if I'm in a rehab hospital, trying to find the dining room, this is very difficult for them because they have an insufficient search pattern of their environment. They're very insecure if they're not in their home or their environment that's familiar to them. So we force these clients to go from the acute care hospital to the inpatient rehab facility or the skilled nursing facility, and none of it is familiar. It all looks different, and the colors look different, and the people are different. And so we cause a lot of visual stress for our clients because of that. So it's important for us to acknowledge that and communicate that to them as they're beginning to learn this new environment with us. Social participation is really limited because they're very anxious, like we talked about, in a crowd or in a dynamic environment where everything's moving fast. So they become very passive. They don't communicate. They rely on somebody else to tell them what's going on, someone else to be able to communicate who's coming into the room. And this is when you can really get to where people isolate themselves and just want to stay home because of that fear of what can happen when they're in that environment. So it's important for us as clinicians to walk through what is important to them, what are social activities that they want to be a part of, and let's walk through some strategies of what you can do with your visual field cut and how you can manage it so that they don't isolate themselves. And then reading. So reading is involved with, a leisure activity, but it's also involved with everything that we do. So even just cooking, you're going to have to read either the back of, maybe a menu if you're eating out, or maybe a recipe if you're cooking at your home, or maybe you're just trying to read the ingredients on the back. So if your fovea is impacted, then your reading is impaired. And so then we take into account the perceptual span. So like, what are you seeing when you're looking at it? And then that's impacted because of the visual field loss. And so that might be more right versus left. And so we have to work on those tasks in therapy. We can't avoid that. We want to look at that and look at their speed and accuracy and make sure that we are identifying where that cut is so that we can communicate that to them and teach them strategies to manage that. So hemianattention. So we talked about hemianopia. So now many of you probably never separated that into hemianattention, but it is different. And so this is that impaired or lost ability to react to that sensory information that is presented in the space contralateral to the lesion. So if we know that just from looking at the slide with vision, if this is on the opposite side, I don't attend to that side at all. This is the most severe form. So this is our client that keeps their head situated to the side that's unaffected, and we can't even get them to midline oftentimes. It is the most severe, and more often does this happen in right hemisphere lesions than in left hemisphere. You see more left neglect than you do right neglect. It's grouped into 3 different categories. So there's lateralized bias, there's non-lateralized impairment. And so when we look at that ability for us to be able to attend and search space, the non-lateralized involves arousal and attention. So this is our client that sleeps significant amounts of time. We put them in a chair for therapy and we bring them to the gym and they go immediately back to sleep. So they can't focus, they can't shift, and they can't sustain their attention. And then that lateralized inability to map and build that internal representation of the left space in our working memory. So remembering things and being able to use our working memory to pull from that. And remembering that we have a left side of our body. That's that lateralization part. So spatial bias is one aspect that is communicated within the literature with someone who has hemianattention, and that's our impaired ability to explore space on one side. So typically, like we said, a right side involvement, left side spatial bias. So they're going to be more attuned to the side that's unaffected. Our visual search is limited to the unaffected side. We like to try really hard to get them to midline and then get to the affected side. But if you have a spatial bias, you're going to stay on that unaffected side only, which this is the client that when they're eating their meal, they're only eating the things that are on the right side. They never see what was on the left side. So, they have that bias to that, and you can identify that. This is also the client that only shaves the right side of their face, and you have to do verbal and physical cueing to get them to shave the other side due to that spatial bias. So you can imagine that activities like walking and driving and reading are greatly affected if we are only going to be biased towards the side that is unaffected. So non-lateralized attention, we mentioned this as one of the different types. This is our client that in addition to the visual field cut and the hemianattention, they have no arousal and they cannot sustain attention levels. So this is a really severe aspect in presentation for our clients. They lose focus, they drift off, they disengage, they shift attention. They're not able to sustain any type of functional attention when they're in this aspect within their brain injury recovery. So this is a very difficult client to rehab, and a lot of times these clients are sent to skilled nursing and not inpatient rehab because they can't tolerate that 3 hours because they don't have sufficient levels of alertness and sustained attention. And that mental representation of space that we discussed on a couple of slides back, we know kind of where everything is in our home. We have that mental representation before even using our eyes. Our brain, helps us recognize where that is. So hemiattention results in that difficulty of initiating and sustaining our attention over time. So as a result of that, our working memory and our ability to develop that mental representation of our space is impaired. So we're in a brand new hospital room in a rehab facility, and we are not able to see one aspect of the room, and so we don't know where the bathroom is. We don't know where the closet is. We may or not know where our clothes are located because we've lacked that mental representation. That's that brain component. So objects on the affected side, so oftentimes, the objects that are on the left side, they disappear, and it's as if that side does not exist. So they don't have insight on that. So they may put their left arm in a wheelchair when they're doing wheelchair mobility and have no idea that they've done that because they've lost that representation. So they have difficulty orientating themselves to space in order to effectively navigate their environment. So they're lost, and they're frustrated, and that has a direct representation of not having that working memory to tell us what to do. So some more facts about hemiattention. So in early practice, 25 years ago, we just used the term neglect, and we used it over and over. And neglect is actually the most severe form of hemiattention. So you have both hemiattention and hemianopia when you have neglect. So persons with hemiattention, they have a asymmetrical search pattern. So they're not looking left to right. They're not scanning in a symmetrical search pattern. So they tend to revisit the right side and they ignore the left side. And when I say that, I'm talking about clients who have left side involvement. So they want to just keep going back to the right side. So they may start at midline, go to right side, come back to midline, only go to right side. So they never get to the left side. And that could be with an occupational task, that could be with a paper and pen activity, or it could be with reading and writing. So if we provide cues to information on the left side, they do not have the inability or the inability to incorporate that information. So someone with neglect does not respond to cues, whereas somebody with just hemianopia will respond to those cues. So it becomes a cognitive impairment on top of that. So just think when you write neglect in your note from this point on after you listen to this, is this truly just hemianopia, or is this both inattention and hemianopia? Because if it's both, then you should use the terminology of neglect. So this slide helps you just break it down. So on the left-hand side is hemiattention. Very little effort to search for information on the left side. Very random and unpredictable search patterns. Unable to improve performance after cues. So if I'm giving you cues and you're doing the exact same thing, we're not seeing any performance change. And unable to use compensatory strategies. So I'm teaching them how to use a compensatory strategy for dressing, and they're not able to do it. They only want to do it on their unaffected side. That is someone who has hemiattention. But when we look at homonymous hemianopia, the HH, these clients can compensate for loss of vision. These clients can have a structured search pattern. Sometimes it's abbreviated, sometimes they use a different head position, but they can search left to right. They will come to their uninvolved side. Usually able to maintain attention, so they can maintain that sustained attention to understand what's going on with them. And then they can respond to cues and use it to perform, improve their performance in daily activities. So, somebody with just a hemianopia is going to be someone that you can really use compensatory strategies and teach them how to manage in their world. Whereas somebody with hemiattention, we're really going to involve the caregiver. And we're really not going to give them compensatory and cues because they're not going to respond to it.
Okay, so now let's talk a little bit about ways to assess this and what types of assessments to use. This, and just know we're in no way associated with the BIVABA. It's just like it was a game changer for us when we learned this. And this is another tool that was developed by Mary Warren, who is basically a genius in the low vision world.
She's our guru.
But she came up with this assessment that literally it gives you all the tools, everything you need to assess vision with these clients with brain injury. And just note on here, it can be used in a variety of settings. So, you can use it in hospitals, inpatient rehab, home health, but it's good for clients that have brain injury, CVA, TBI, brain tumor, also MS and more like degenerative diseases and even Alzheimer's disease. These, that any disorder that's going to impact vision, you can get some good information by using this assessment. But it's actually a battery, and by that, there's a variety of assessments. You don't by any means have to use every single one. So you can pick and choose which ones, are pertinent for your client. But just know that it does have tools that you need to assess visual acuity, both distant and when I say distance, it is actually intermediate distant, and reading acuity. There's a contrast sensitivity function test. There's visual field assessments. There's assessments for oculomotor function, as well as visual attention and scanning. So really, that's like catch-all for all of the really important areas that impact function for our clients, and it allows us to kind of handpick what we need to assess for each of those areas, and it's fabulous. And it comes in this little kit that you can carry around and put everything in a little pouch, and it's amazing. So, and within this, within the BIVABA, there are pieces of these different assessment tools as well, but just know, and this isn't standardized by any means, these specific things I'm about to talk about, but ways that you can assess for like hemianattention and a hemianopia is to use cancellation tests, because it can really allow you to see exactly, especially if you put it directly in front of them, where they're not compensating and turning their head or moving the paper. It really helps you be able to see what they are and aren't seeing. So it allows you to know, if there might be a deficit or a field cut on one side. Also, being able to look at their search pattern when they're doing those cancellation tests can tell you a lot about hemianattention versus hemianopia. If it's structured and organized, it may be a little bit different versus if it's disorganized and they're all over the place and maybe they go to the same place over and over again. That can tell you a lot about maybe what the condition the client has. The design copy test is one where you just give them a figure and you put a little template in front of them and give them a piece of paper and they copy. So you can tell a lot about their perception and what they can see, how they interpret that object based on how they draw it. So for someone with hemianattention, they may leave out details on that left side or kind of skew the drawing where there's not even really a left side to it, where it's all focused on the right. Whereas someone with hemianopia may reproduce the whole thing, probably compensating with head turns, but it may not, it's mostly accurate. The design of it may be a little bit off, but that's kind of a telltale sign too, whenever you can watch them, even like drawing a clock and things like that, you can tell a lot about that. Within the BIVABA, there's a scan board, and we've kind of created these, kind of our own design of this, basically like on a whiteboard or something like that. But you can scan 10 numbers that are kind of in a random pattern on this paper, but you want to see their scanning pattern when they go across these, and so you make note of how they read the numbers on the board, and that can tell you a lot. Their search pattern, what they see, what they miss, can tell you a lot of information about if you're dealing with hemianattention versus like a field cut hemianopia. Some other assessments that are good tools to use, the Dynavision, which we use a lot in practice over at our community care clinic, but you can set up different scenarios. You can really get into specific areas that you really want to address, and it can give you basically a printout and then it looks at timing and it looks at visual fields, and it can really help you compare from session to session too if the client's improving. So it's a really great way to look at reaction time and the visual field search, and it can be used both like with intervention and for assessment, like for that initial assessment too. Scan course is another assessment that's described in the BIVABA, which we've kind of used in different aspects in intervention and assessment too. But you basically are going to set up targets as someone either walks or wheels down a hallway, and you want to have them tell you what they see along the way. And so you're going to have them scan from left to right, and it kind of lets you know basically how their scanning pattern is, how efficient they are when they're scanning, and if they miss certain targets, if they can go back and correct them. So there's a lot of things that you can look at and learn just going through this particular task. And then some of the other assessments that are good for like reading, there's the Pepper test, which is the VSRT, the Pepper Visual Skills for Reading test, and it can let you know a lot about reading for someone with hemianopia versus hemianattention. It can kind of tell you a little bit more based on the errors the client makes and give you something good to something good outcomes that you can actually look at. The telephone number copy test is also where you have your client copy specific phone numbers, and the numbers are on your left side, you copy them on the right side, and you're looking at how they read and their accuracy, so you can definitely tell a lot about their search patterns and how they interpret the information and write it down based on watching your client do that. And also it's a time test too, so you can see how efficient they are with their scanning as well.
All right, we're going to get into some intervention, and we will go through these. We've provided some pictures as well. So what is in our OT toolkit for treatment of oculomotor impairment? So oculomotor impairment, we talked about this earlier in the PowerPoint just to describe what it was. Our really only thing that we do for that is occlusion and use of filters. So we're doing that to decrease visual stress and any other symptom that they may have as a result of that, of the double vision. And our interventions are going to be very occupation focused because that's what we do as occupational therapists. So we're going to look at task and environmental modification. So how can we set this up so that they can participate in their environment? And how do we modify routines and habits? So with occlusion, so 25 years ago, we just put a patch on them and did a monocular occlusion, and it's used for clients experiencing double vision for cranial nerve lesions. Usually temporary. Research says 3 to 6 months. It can be permanent for some conditions, but as far as that goes, they're going to deal with this for a significant period of time. Focus of our intervention is on symptom management so that we can decrease their visual stress through occlusion so that they can participate in occupations. So just know that a complete occlusion that I talked about that I did 25 years ago is really, I would like to be able to do partial occlusion. The research really shows that by allowing them to still have their peripheral visual field, that we decrease that visual stress. So there are two forms. Complete is like the patch. And then partial, we're going to show you a picture. It's with using transport tape. There is no therapeutic purpose other than trying to get rid of that double image. Okay, it's not strengthening the eye. It's not helping with binocular vision. But what it's doing is allowing them to see what they can out of the one eye that doesn't have with just using one eye rather than using both eyes. So this is not something that is a catch-all. This is just to be able to allow them to participate and decrease their visual stress. Oftentimes you're going to see that they're doing it anyway. They're holding their hand over one eye. They're doing what they can to be able to see the image without seeing two, because that's very disturbing. This is what partial occlusion looks like. So on the left-hand picture for me is the spot occlusion. So that translucent tape is placed in the center of the lens on the non-dominant eye. So go back in the PowerPoint as to why it was important to know which one is the dominant eye. So the intervention states to use the non-dominant. And then the nasal occlusion, so going towards the nasal portion, so towards your nose, is still using the translucent tape and placing that over the nasal portion almost to the central field of the non-dominant eye. So you're going to want to practice this with your clients and make sure that that double vision has gone away once you use this as an occlusion. It remains on until they don't have the diplopia. Or as how much the patient can tolerate it. So occasional adjustments may have to be made to decrease the amount and the width, the size of that occlusion that you're using with your tape as their fusion begins to increase, so as they start to heal. So, closer to 6 months, you're probably going to not need it to be as wide as you would in the beginning. So you have to, monitor these clients and educate the client and the family within that.
One thing I want to add to that is this is something you're working alongside the physician with. Like if you're in inpatient rehab, this is something I'm communicating and working alongside, like the rehab doctor. So they kind of know what's going on in the reasoning. And honestly, you may have to educate some of them on partial occlusion because old school pirate patch is just the way to go. Yes. And so this is a little, it's a little bit new. And so it may be something you have to educate others on.
Yeah, and we have a great research article. If you need that information, you can email us. Our email addresses are on the second slide of this presentation. You're welcome to email us and we can send you the research that shows the importance to try partial occlusion before you just use the patch and do the fully occlusion.
Okay, so these are just some intervention strategies, and honestly, they can work in a lot of situations, alongside the situation of a client with vision issues from brain injury. But just contrast whether they have a visual field deficit or, contrast sensitivity issues, but adding contrast to their environment is just going to make them safer and independent. And it's kind of a no-brainer for us as OTs, especially at home, to set up things where they can see them well and to add to their safety, but also in the hospital setting to add some contrast within that environment so they can, find the light switch and find their call light and find the door to the bathroom and things like that. And so it's important to add that in their environment.
And the BIVABA has a tool that you can assess their contrast sensitivity. So that's why we assess that at the beginning too. So minimizing background pattern and clutter. And so I'm sure you've seen this if you've done home health or you've done home evals, but clutter and background patterns are, almost in every home, especially in a lot of our older adult homes. But if you can minimize and organize that and teach your client the importance of that, then that decreases their visual stress. And that's a tool in your environmental modification tool belt within being an occupational therapist. This helps everyone, but with somebody with visual stress, this is primary. This is going to make them be able to navigate their world much safer.
So environmental modifications, even things like, we talked about the glare sensitivity. So paying attention to the types of light that you have, sometimes that fluorescent light is really too much for these clients, which is when you may, need filters for things like that. But even like in the home setting, adding, lamp light instead of having to turn on overhead fluorescent lights. Even paying attention to like your curtains and making sure there's not too much glare in the whatever room they're in. But again, we talked about contrast, adding like bump dots, things like that, so they can compensate with like a tactile sense versus needing to use their vision. Relative distance and size just means if they can't see something smaller, make it bigger. So if you're giving them a home exercise program, then make sure it's big enough that they can actually see it and read it. And that's common sense, but that's something that can make it so much easier, for our clients and family members to be able to read what it is that we're trying to educate them on. Again, the visual distraction, minimize that, decrease clutter, and just organize the environment to try to kind of have a place for everything, a place for their coffee, a place where they're going to take their medicine, maybe have a station for their medication management, things like that.
Add lighting. So lighting is something that makes a huge difference in the visual stress after somebody has a vision loss after brain injury or just age-related. So some qualities of good lighting is listed for you. You want it to be even. You really want to look at minimizing glare. So you may have to use curtains and blinds and things like that in people's homes so that they don't have glare, especially where they're reading and doing those fine tasks like eye-hand coordination, like knitting and things like that. Flexible placement and then maximum lumens. And so that's about how much light. And really, this is very specific to the client because we all have things that we like and we can see better out of. So you want to do this in conjunction with communicating with your clients. So if you're going to try different light bulbs, have them with you. Don't just change it for them. Some just general rules of thumb is that fluorescent lighting gives you that even illumination, but it's not as intense, it's more diffuse. It can be irritating to a client with brain injury, and you really have very limited flexibility as far as where you place it. Fluorescent lighting bothers me, and I've not had a brain injury, but it does bother me. Halogen lighting, some advantages to halogen lighting is that it's really high quality and has really good intensity and really doesn't have much glare to it, but it's hot, and so that poses a safety risk for our clients, and it is less flexible on where you can place it. LED lighting, which is really kind of where we are right now, just as far as the world and what you can buy. It is high quality, it is high intensity, it does have less glare, but it is a lot more expensive. So some of our clients are not going to be able to buy that. Gooseneck lights that you can move and really get close to them is something that was recommended to us when we went through this program, and we both recommend that for a lot of our clients. So as OTs, I think it's important that you look at direct and indirect sources of lighting in the room. And so what is direct? That's going to be from a fixture or from a lamp, and indirect is what you're going to see from being able to have, like how much sun is coming into your room and the light that comes in from a different source. So look at both direct and indirect when you're with your clients.
So light sensitivity, again, we've talked about that a little bit, but that is a tool that we can have for our clients to help them with that. And really different clients, and depending on their diagnosis, may respond better to different colors of the different glasses, but just know the filters are going to help to reduce and control the light to the eyes, and hopefully it can be a temporary thing, and hopefully, depending on inside versus outside and what the light source is, you can figure out what works best for them and trial some different ones for them to use.
So enlarge, so consider both size and contrast. So contrast is something that really we take for granted, but it is so important for our clients after they have vision loss after a brain injury. So these are just some examples. So you can buy, if they like the leisure task of playing cards with their family and friends, then you can make that larger, and you can find that just about anywhere now. There's larger print word searches, there's larger print Sudoku, there's larger print medication boxes, there's dominoes that you can make larger, and then in your therapy gym, if you work in a therapy facility, you can have, you can create some of this really low cost that you can do with them and see if it enhances their performance. So home exercise programs and anything that's going home with them with literature on what they need to do after discharge really needs to be an optimal size that they can read it. And so as a clinician, you play a role in this, and you can communicate that to your staff members once you know what acuity is best for them so that they can see that.
So structure and organization, this is going to be really important for your clients with brain injury, and thinking along lines of at home. I know we talked about stations, but being able to be independent with things in the home environment, like within the kitchen, if they want to be able to get back to cooking, make sure that they can reach the items and that they know where they are. So whether that be labeling them or have a set station that they go to for that, junk drawers are going to be really hard for these clients, even though they may be used to that. You want to have things accessible where they know where they are. There's medication organizers, a coffee station to organize, what you use each day to make things easier and safer from both a cognitive standpoint and a safety standpoint, and just to be more independent with that task visually.
So simplifying and removing steps that require vision. So this is a cognitive strategy. So if you can eliminate vision with doing some tasks that they do on a routine basis, then that helps them be more successful. So instead of making cookies from scratch, we can buy pre-made. And so you can even go a step further, and they've already pre-cut the cookies. And so that makes it, really simple for somebody to be able to do. Instead of cutting our vegetables, maybe we, work with our clients on buying them already diced and cut for them. Really all of this is available now, and that's a blessing for our clients with low vision. You can now get your prescription sent to you with all of the medications that you take all put together in little punch-out boxes. So if they're having trouble with medication management, then address that. If they can't pay bills and write checks because of their vision, then they can go to automatic bill pay, and that can be something that as a clinician you can work on in your therapy session. And then you have a lot of access to change things within their phone. Being able to communicate with others is absolutely necessary for safety. So walking through, if they use a cell phone, walking through that and changing that to change the font, to improve the size, looking at how they use the voice activation, those are all things that are wonderful for us as occupational therapists to do, because that allows them to then participate with others and to be safe in their environment.
So just basic interventions, just what your goal is going to be when you have someone with decreased acuity, is just to make visibility better for them within their environment. So you want to increase visibility of the task and the environment, and that can enhance your client's ability to perform that.
So interventions for ocular motor dysfunction, we want to enable our client to manage that impairment to allow for participation in valued activities. And so that might be with a partial patch, or it may be with a full patch, so that they can then participate in mobility or grocery shopping or cooking or whatever they need to do.
So interventions for visual field deficits and issues with attention and scanning, our focus is going to be on compensation and teaching them how to use what vision they have left and remaining to compensate for that affected visual field. And one thing to remember, it does require awareness and insight and attention, which may be lacking in those clients with actual neglect. So that's important to remember, that you may not get a return in those things for those particular clients.
So why OT and low vision? Because we are blessed to have a holistic understanding of both aging and disability, and we've also been blessed to have a really great foundation with anatomy and neuroanatomy. We understand the role of context and how it influences their capability and their disability. So we are absolutely the people that need to be on the front line treating low vision with our clients. And then we wanted to leave you with this. So this is our OTPF, the Occupational Therapy Practice Framework. And so if you're an older clinician like us, we'll call that seasoned or wise, I guess, maybe not older. You may not have seen this, and I wish that everyone had their hands on it. But this is the official document of AOTA for OT practitioners. And I want you to know that within our domain of practice, vision lies under client factors. And then, as we discussed in this whole presentation, that what we do is how do we improve their ability to participate in valued occupations. And that can be through ADLs, IDLs, health management, work, leisure skills. So recognize that vision is in your domain of practice, and that our focus with low vision is their participation in those valued occupations. So thank you for attending our presentation today. We do have some references that we have on our slide. And then remember that at the very first slide, we have our email address. So please, if you listen to this, there will be a post test that you will do. And we will have a Google Doc linked for you within this webinar that you can fill that out. If you make 80% or higher on that, we will send you a certificate for CEUs on this. So thank you for joining us, and we hope you have a great day.
Thank you.
Thank you for joining us for this webinar in celebration of UCA OT's 50th anniversary. Please be sure to visit the UCOT website to complete the post-test and provide your contact information for a certificate of completion. Be sure to join us for our second podcast over assistive technology in May. Have a wonderful day.